Eric, I want to ask you actually. So seeing Seyun, he's a bone marrow transplant recipient, and you were a nurse for 14 years with survivors. What sort of reactions or thoughts or did you guys have trouble building these teams, and did you see problems or opportunities? What sort of reactions do you have hearing that?
Yeah, a couple of things that I heard, and really it comes down to two areas, I think, and one is um, the idea of territory,
Mm.
and being able to float through another person's territory, and what is the reaction of that of both parties. And I know it's certainly, I'm sure, easier with a nurse and a social worker than it is maybe with other disciplines, but even so, when I would start perhaps talking about something that was more supportive, or trying to go a little deeper with a person in the social work realm, that was not looked on terribly well in the beginning, and I certainly started to get my back up when a social worker may be talking about managing a side effect, and so there's definitely that idea of territory, even when we don't want it to be there, and we try to put it back. And so I think one of the things you said in an earlier session today was about ego, and it does have a lot to do with ego and letting go of ego, and sort of saying, I'm not more important than another piece. And how do we teach that, and making sure that we teach that and sort of take that ego out of the equation. And then another piece of this, I think, is healthcare literacy, and educating people the way we're educated. I know if I needed something, I would know exactly where to go to get it, and the general public has none of that. And I think there needs to be a piece of the social contract that is dedicated to healthcare literacy and making sure that people do have those tools to get to understand the system, and it's no coincidence that there's a rash of navigators all of a sudden across the country, navigators for almost every discipline, very big in oncology, because it's so complex. The system has to be navigated by a third party, and I think that's something that we really need to think about as well.
That's excellent. I mean, my Judy was talking about her husband, and my aunt actually is a polio victim and is in the ICU in India right now. And my parents had to rush over there, and they've had a very difficult time navigating the system. And so, Himanshu, thinking about India, I mean, what sort of lessons can America learn from India, and what sort of lessons can India learn from America in this question of transdisciplinary professionalism?
That's interesting, because when you pose this question, you're talking about two societies in which the role of different professionals within the system are viewed in very different ways. Here you would have nurses sitting in the same room, occupying the same chair, and talking to you as equal partners. Whereas if I talk in India, placing myself as a doctor, I don't see a nurse coming up so easily and approaching me and saying that this is what I think you should be doing next. But this places me in an opportunity as well when it comes to transdisciplinary initial efforts that you're actually seeing. The barriers will be a little easier to probably break down if it probably comes from the right champion, from the right people, because still there are people who would hear across, okay, he's a doctor, he's a person in authority, probably he is going the right or suggesting the right thing for all of us. It's maybe making sense for India to look upon this as an opportunity rather than as a threat at this point of time. I mean, it's radical to think of it in that sense, but maybe that inequity between the two professions is probably going to be something that you can tap across to build something which is a little faster and neater.
Interesting. And Dave, you're now working sort of at the VA. Are there opportunities, or what have you seen out there with the Affordable Care Act, the VA, and all this going forward?
Sure, and I see Dr. Malcolm Cox is here. He can speak about this much more articulately than I can.
Well done, Dave.
With that proviso, I'm happy to start, and Dr. Cox can finish. But I think actually one program that is in Dr. Cox's wheelhouse is something called the Centers of Excellence in Primary Care Education. And I think the fundamental principle that program elaborates on is the idea that we are in a particularly special time post-ACA in the United States, where the health system is changing. It's changing rapidly. There are new models of care like accountable care organizations or the patient-centered medical home, which are gaining significant currency. And in my experience, although there are certainly bright spots that people in the room are responsible for, health professions education as a whole has not kept pace with that rapid transformation. And so this program, the Centers of Excellence in Primary Care Education, is a demonstration across 5 sites in the VA, 5 medical centers where they are doing the nitty-gritty solving day-to-day challenges of what does it mean to align the curricula and schedules of a medical school and a nursing school in a particular area. How do we actually just physically get all the right people in the same room at the same time to take care of a shared panel of patients? And I think that's the first hurdle that really has to be crossed, is getting the disciplines around the table. And I think sometimes we don't think about those operational challenges because, you know, they're not the intellectually exciting pieces of what we do. But I think that's the foremost challenge that I see being addressed well by the Centers of Excellence program.
Excellent. And Judy, you mentioned a couple of things that I want to pick up on. You mentioned Appalachian apathy. And I was wondering if you could unpack this apathy. Where does it come from? Does it come from patients? Does it come from providers? Does it come from society? Like, where does the apathy originate from?
When I first saw this, it was visiting out in West Virginia, and I described it to one of our health policy audiences. And an African-American woman came up to me and she said, "You're describing exactly what I have to live with in Mississippi." People who for years and years have very low expectations of what they can do for themselves, how they can even talk candidly to a nurse, much less a doctor, and who sort of go along to get along, and it's very hard to motivate them to pay attention to their drug regimens, to do exercise, to eat better, because, you know, my family did all right without that. I'm not interested in going to a center of excellence. I wouldn't know what the thing is. I don't know what good medical care or health care is. And it becomes pervasive, and where the doctors then say, I don't even offer some things to certain people. Well, to me, that's unethical. You should at least be letting people know what the possibilities are and explain why it can make a difference. We know that doctors can help, or nurses too, can help people lose weight if they're, you know, sympathetic to that. So how do you empower a patient when you just assume they won't use the information? It's a self-fulfilling prophecy. But can I go back to something
Please.
that I think that what we're really talking about here is moving beyond the academic health training modes and what goes on in the teaching hospital, and saying that's only part of what we really want healthcare to look like and where we're going to need to train people. And we want a much broader continuum of care that includes more than doctors and nurses and pharmacists and social workers, but it includes AA, it includes Narcotics Anonymous, it includes caregivers, all sorts of other organizations. And this multidisciplinary, transdisciplinary team is going to be much, much broader, and in fact, very empowering to patients at different times in their lives. So I have a suggestion to make, just because, you know, it's easier to shoot somebody down. But I'm sure a lot of you know the work of Eric Coleman and Mary Naylor on care transitions, and we've got the work of Harlan Krumholtz on post-hospital syndrome, and we've got the work of David Rubin and Mary Tinetti on care and making trade-offs. I really think that if we could move away from just looking at a medical diagnosis and a rule out of certain things and really looked at goal-oriented care plans, it empowers a role for everybody depending on what the problem is at the time. Sometimes you just need a checkup to say you're doing okay. Other times you really do need to see the highest technology empowered person, whatever the may be. I don't know, you all know medicine better than I do. But I think that there are tools that we could be applying that would facilitate putting into practice the kind of social contract you're talking about. You all are doing it anyway, but we have to make it more visible. We don't want government to do it. I know how bad government is. Great idea, and by the time it comes out the other end, it's a mess. So you all could be doing a lot, and I'd love to see you thinking about what are the tools that you could apply, both in training and then in practice, that would empower students in new ways of doing business. I just brought the care plans, goal-directed care plans.
Excellent. Well, I'll pick on you. So do you have reactions to that? I mean, as a lawyer and someone who thinks about sort of structural changes, do you think the theory of change must start at the government level, or do you think it's rightly to start at the education level or at the student level?
I'll give the classic lawyer answer and equivocate. It depends. In certain situations, you absolutely need government to coordinate and initiate a systematic change. In other situations, however, the right political incentives just aren't present or not present in sufficient scale to warrant government action. For example, even though cancer is pandemic in Africa, it's not really a high political priority in comparison to other more visible diseases like HIV or malaria. And so to really push for improved access to cancer care, you can't sit back and wait for each national government to pick up the ball. Really, what you see is groups of individuals or private institutions are popping up here and there and saying, we need better care, or we need better education, better screening, and things like that. However, in order to really institutionalize these changes and to coordinate these individual clumps, there is a role that really only government can fill. One of the panelists mentioned the operational difficulties of getting people to sit around a table and just discuss outcomes and plans. And really, I've found in my experience that government is one of the best facilitators for that. They often have the reach and the connections and sort of the third-party perspective, as opposed to being entrenched in one of the silos that I mentioned. Sometimes government can provide that backdrop that facilitates discussion. So it really depends.
Dave, I'm curious to your response as someone who, you're, I'm a student now, and you were a student not so long ago and a resident. What's your perspective on this question?
Sure. So I agree wholeheartedly with it depends. Let me try to give a different framework around it, though, which is that government does certain things well, as Sayun pointed out, and I think one of the things that it does well is set the goalposts, where sometimes it's difficult to generate consensus. And so building on the idea that Judy mentioned, and maybe to get a little bit in the weeds for a minute, I think having the right metric that everyone is organized around is a fundamental problem that is soluble. And so if we figure out better ways to measure health, and there's some ideas certainly that have been out there for a long time, such as health-adjusted life expectancy, which combines certain objective measures as well as some more subjective or patient-decided measures into a composite measure, then you have kind of a bottom line goal that the various elements of the health system can actually work together toward. So I think, perhaps that's a place where government can actually move things forward. Now, in terms of actually doing that, and particularly at the local level, I think that's where people need to get out of the way and allow, these innovations and the different approaches that we've already heard about to flourish. But I think if there is some unified approach to measuring what it is that we're all trying to accomplish, then that could advance us.
Okay. All right. Well, I want to start to open up this panel to the audience as well, because I think we actually have an opportunity to have a debate with students and with patients and with providers on an important question of, is this actually real? When I was telling my mother about this transdisciplinary professionalism, she had no idea what I was talking about. And when she watches this, she's probably going to be upset that I mentioned that. But, Sally mentioned this. Someone mentioned professionalism movement. Is this a movement? Is how we communicate this, is this going to stick with society? Are we talking about the indicators? Is there a common vocabulary? And I don't have answers. I agree with everything that's been said, but I also don't know, taking a next generation perspective, what's going to happen in 25 years. I know that there are 80 million millennials right now. It's one of the largest blocks in American history. They're all connected through Facebook and Twitter. They're all on email. And they're eager and they're keen. There's been the rise of social justice and global health curricula, an explosion of it in the past 15 years on American campuses. But what does that mean? A lot of my colleagues, as they transition from students to young professionals, talk about losing their idealism, kind of becoming wizened, or, and I was talking to Dave about this. Maybe I'll kind of go back to you guys in terms of your stories. Have you felt, as you've sort of evolved, you have these hopes on, marrying multiple disciplines and being an innovator? Have you felt that your idealism has taken a hit, that your humanism has taken a hit, that you've had to protect your turf for financial reasons? Are there barriers that you guys see, or is that just a part of growing up? As you transition from a student to a young professional to professional, you start to protect your turf a bit more and become a bit more wizened. What's going to change? Eric?
Yeah, I think that many young students, so the older you are as a student, I think maybe you're a little bit more mature, and you're coming in with already altered expectations. But the young people coming in seem to, the young nurses that I teach seem to really have this very altruistic view, and then later, a few years later, you see them on the floor, and they look beat down. So yes, I think that sometimes we do get beaten down. However, I feel like there is a movement afoot. For me, I see it in more prevention-oriented. I hope it's transdisciplinary professionalism-oriented. I don't see that as much, but I do see people talking about looking at optimizing health rather than just treating people at the time that they are not healthy anymore. So I do feel like that part is very positive, and I have lots of hope for the future in that realm. And at the same time, with the transdisciplinary stuff, I think it feels to me like it's a bit of an uphill battle as an integrative practitioner. Selling yourself to the more traditional community it does feel like an uphill battle still at this point, even though we have a lot of prevention talk
Himanshu, I see you scribbling.
In India, at least, consumerism is on the rise. A simple evidence of this would be in terms of how do students, medical students, choose their fields of specialization. We do have an option that you can end your medical education at the graduate level, come out with an MBBS degree, and choose probably to go across with an MD or an MS or a specialization. At our times, the frequent choices for students were to go across and do internal medicine, cardiology, or even at times radiology. And the only probable driving force between them for these choices were not in terms of what the specialty has to offer in terms of challenges, but because the private sector in India is so rapidly growing as to which field is the most remunerative. That's consumerism at its best, and probably not the right way in which we look upon this field that's developing further. So that's a stroke of pessimism that I have in my voice.
Others with pessimism or optimism for the next generation?
Hopefully optimism.
Okay.
When I travel around the country and I go to places like Denver Health, Geisinger, other places where they are really innovating new systems of care, there's a much different sense of professionalism, excitement, shared value systems. I think one of the problems is that we have a lot of good interdisciplinary training going on in medical school, nursing school, etc. But then you get out into your rotations that deny a lot of the things that you learn, okay? And then you go and you get hired by some big hospital system or insurance company. But I would like to think that visions of what this reconfigured healthcare system could be would be empowering to young physicians and nurses practicing together, so that health professionals are professionals driving the system as opposed to entrepreneurs. I'm not saying that doctors who run big hospital systems are venal, but to a certain degree, the money has taken over, and they'll even admit it. And so I see this professionalism as an empowerment tool for you all. Get with it, folks, because I'd rather go to get my care in those kinds of places and working with you than just going to an organization that is driven by what the insurance rubrics say from Milliman and Roberts, or Milliman and whatever, or what Aetna says they should be doing at Innova here. You know, they formed an ACO. Well, who are they accountable to? The shareholders or to me and my husband? That's how I'm looking at it. Pollyanna.
No, I love it, and I think we need a national awakening of that consciousness of, I mean, when we say social contract, is this just a term that we read, or do we feel it in our blood? Because I'm curious, when, Judy, when you first saw that the name of the panel was a social contract, what was your initial reaction? Was it one of hope or one of...
I hoped it wasn't airheaded. I hoped it was real.
Right.
And what I heard today is people struggling to make it real. And what I think what needs to happen is you need to work on this, and then those of us in the policy arena can do, as we heard earlier, take good ideas and then spread them somehow, fund them in different ways. Government isn't really good at creating from scratch. It is good at capitalizing on things. So when we passed the ACA, the goal was really to reduce variation and get better value per dollar. And then the Supreme Court came along, and now we have all these different legislatures. And so we're going to have very different constructs at work in different states and even markets. Well, over time, I think the government is going to continue to push to capitate however much it needs, whether it's bundling or global budgets or regional budgets. And then we're going to step back and say, now, wait a minute, we have all these natural experiments going on from one state or market to the next. Where are we getting the best value per dollar? Where do the professionals come together and do better and like the practice better. Because I suspect if professionals like their practice better, patients are going to do better. And then I think that's when we will start to say we have got to spread these new models. And you all are the start of it. I like to think.
Okay, yeah. Or I think we have to start a student question first, and then we'll. Is the AMSA representative here?